I was asked to tell you something about the changing world and the emerging field of anti-obesity medication. And you already heard a lot about obesity by the two previous speakers, but I just wanted to highlight the fact that obesity is in fact a real disease. It is stated so by several international associations like the EASO and the World Health Organization, also the Endocrine Society. And if we talk about a disease, it also means that not treating obesity is not an option. We know that there are several complications and comorbidities related to obesity, and so we should really change our mind and start seeing it as a real disease. We already say it is a disease, but as a matter of fact, when we see patients, the first thing we tell them is, you know, you just have to eat a little bit less, you have to move a little bit more. That's not treating a disease. That's not how we treat hypertension. That's not how we treat hyperlipidemia. So we have to change thinking about obesity. Now, so what do we have in our pocket when we want to talk about the treatment options of obesity? We have the lifestyle modification, which was slightly touched upon by Veronique. And then we have pharmacotherapy and surgery. And the main question, and I will not be able to give you an answer to that today, is when do we start treating patients with what part of our treatment options? When will we say this patient now needs a pharmacotherapy or this patient needs to be sent to the bariatric surgeon? Is it based on BMI? Is it based on the new EOSP classification that you just heard about? Or is it based on individual needs? We don't know yet. And before going a little bit further into that, it would be wise if we want to tailor the therapy for our patients to dive a little bit deeper into the pathophysiology of obesity. Now, what do we know about the pathophysiology? As I said, obesity is a disease, so there's a complex change of all kinds of hormones and adipocytokines behind it. And in fact, there are two main pathways. First of all, there is the energy homeostasis pathway, which means that after a meal, what happens? There is a gastric dilatation, and this gives rise to the secretion of GLP-1, of insulin, of other gastrointestinal hormones. These go and action into the brain, into the hypothalamic and the brainstem region. And on the other hand, you have the environment, the hedonic pathway. Things like other people that are eating just in front of us, or a nice palatable food just in front of you. This will also give rise to a lot of stimuli going to the thalamus. And the combination of all these stimuli will go and act on different receptors. Receptors within the POMC and the MC4, the melanocortin-4 receptor pathway. And by either stimulating or inhibiting factors or hormones on this pathway, you will have either an increase in appetite and satiety or a decrease and changes in your metabolism. Now, when we want to talk about the medication that is available, I wanted to highlight there's a lot of medication, I will come back to that, but I wanted to highlight those who are approved for pediatric obesity. And in fact, we have 5 medications at this time. We have Orlistat, which is approved by the FDA, not in Europe, and which can be used for treatment of children from the age of 12 years onwards. Then there is the combination of phentermine and topiramate, which is also only approved by the FDA, not by EMA. And then there is, I will come back to all of them later, liraglutide and semaglutide, which are GLP-1 receptor agonists, and those are approved both in by EMA and by the FDA. Those can also be used from the age of 12 years onwards. And then there is a specific class of setmelanotide, which is in fact an orphan drug used in specific forms of genetic rare forms of obesity, such as Bardet-Biedl syndrome or leptin receptor problems. I will not go further into the last one, but we'll touch slightly on each of the 4 upper ones. I already showed you very briefly the pathway of the hormones involved in obesity. And when we now take a look at the different molecules that are approved for pediatric obesity, you see that some of them act only in a central way, like the combination of phentermine and topiramate, but they do not act via the gastrointestinal pathway. Orlistat, on the other hand, only acts via the gastrointestinal pathway, but not via the central pathway. And then the GLP-1 receptor analogs, they combine both action. So let's go through all of them very, very briefly, just to give you an overview. The first one is the oldest one, it's Orlistat. What is this? This is a lipase inhibitor. So when you eat fatty food, your fats will not be cleaved into triglycerides, and by this will not be able to be absorbed by the body. So you will have a lot of fat in your stool, and you will lose a little bit of weight because there is less absorption of fat. What does it give? The studies, which are more than 10 years old now, they show that there is a nice decrease of weight, but there is approximately 5 to 6 kilograms of weight loss when you treat the patient for 1 year. And there were several side effects, mainly gastrointestinal side effects. Because of the fats in the stool, you have diarrhea and flatulence and a lot of gastrointestinal side effects, which in fact our adolescents don't like at all. So in practice, we do not use this molecule, although we have it available for a long time, and it's not approved in EMA either. The second one, just wanted to show you the combination of phentermine and topiramate for the treatment of obesity. What is this? Topiramate, we know what it is. It's Topamax. It's used to treat epilepsy in children. The other one, phentermine, is a norepinephrine reuptake inhibitor, and it decreases appetite. So it makes you feel less hungry if you take this medication. It also has a nice effect and decrease on weight as long as you keep taking the medication. And it is approved, as I said, only in the United States at this time. As side effects, there are an increase of heart rate and dry mouth, so you cannot use it in patients who have hypertension. It's a contraindication. And it is commercialized under the name of Ximia, but it is not available in Belgium, not for adults either at this time. And then we come to the GLP-1 receptor analogs. The first one is the short-acting GLP-1 receptor analog, which is liraglutide. And how does this function? Liraglutide, or GLP-1 receptor analogs, they increase the secretion of insulin and decrease the secretion of glucagon after a meal. So the drug was first invented to treat diabetes. But it also decreases gastric emptying and gastrointestinal motility, which gives rise to a higher and a faster satiety, less hunger. And as I said already in the beginning, it has a dual way of actioning. It also actions centrally via the brain on GLP-1 receptors. And there it induces less hunger and also a faster satiety. What the studies show in children is that when you treat children for 56 weeks, there is a clear benefit of giving liraglutide compared to placebo, with approximately, I will come back to the changes in BMI later on, but with approximately a 6% change in BMI percentage after 1 year of treatment. It is approved both in Europe and by the FDA and in several other countries at this time. It is commercialized under the name of Saxenda. You should administer it once daily subcutaneously. It is quite expensive and it is not reimbursed at this time, 250 euros per month for the patient. And there is a stock rupture actually, so at this time, unfortunately, we don't have Saxenda available, and I was told until the end of the year at least, and then hopefully we will have Saxenda available again. If we dive a little bit deeper into the liraglutide results, what you can see and what is important for us clinically is that when you give liraglutide to the patients compared to placebo, that 43% of the patients receive at least a 5% reduction of BMI, which is important because we know of several studies that a reduction of BMI of 5% leads to a lot of advantageous health advantages for the patient. So it gives rise to less complications, less comorbidities later on. And compared to placebo, you see that even 26% of these patients had at least a 10% reduction or more of BMI. As for the side effects, there were mainly gastrointestinal side effects, so nausea, diarrhea, constipation, stomach ache, and these side effects appear more frequently in patients receiving liraglutide compared to those receiving placebo. But if you dive a little bit deeper, you see that the side effects mainly appear within the first month of treatment and then slightly wean away. So when the patient continues to take the drug, usually they don't get any side effects anymore. And this is also the reason why there is a dose escalation of the drug. So you start with a low dose and then little by little, weekly by weekly, you go up with your dose. Let's move on to the last one, semaglutide. What is this? Semaglutide is also a GLP-1 receptor analog, but it's a long-acting one. By replacing additional amino acids, it is degraded not as fast as the short-acting, as the liraglutide, and it should be given only once weekly instead of every day. What does it do? The other pathway is exactly the same as for liraglutide, so it also delays gastric emptying, increases satiety, and decreases hunger. And here the study results are even more impressive than the liraglutide ones, because after 68 weeks of treatment with semaglutide, you see that there is about 15% decrease of BMI compared to placebo. At this time, we don't have it. It will be commercialized as Wegovy, and in the States it is already available, in some other countries as well. But in Belgium, we don't have it available yet. It should be administered once weekly, as I said, and we don't have a price setting yet either. If you dive here a little bit deeper into the results, you see that when I just talked about the 5% decrease of BMI in liraglutide, about 40% in liraglutide, we have 75% of patients treated with semaglutide who end up with a BMI decrease of at least 5%, which is very, very high. And we never had that with any other drug until now. As for the side effects, the same story as for liraglutide, also mainly gastrointestinal side effects like nausea, vomiting in the beginning of the treatment, and also these side effects disappear and wean off after 1 or 2 weeks slowly. What about the long-term results, and what about cardiovascular complications, or a decrease of cardiovascular complications? Well, we don't have much data there yet. There was some data from a 2-year follow-up study in adults where we see that there is a decrease in cholesterol, in blood pressure, in mainly most of all the cardiovascular risk factors. But in adolescents, we don't have this longer follow-up yet. What is being done now? There is a post-hoc analysis being done on the data of the semaglutide study. And it just showed recently that for the liver function, for example, for NAFLD, there is also a beneficial effect, and that AST and ALT levels and scores of NAFLD and NAFLD decrease by giving semaglutide. So if we summarize the outcome of weight loss in those FDA-approved anti-obesity medication, you see that at this time, semaglutide has the best results from all of those who are approved at this time. And this is one of the reasons why recently, in the beginning of the year, the American Academy of Pediatrics just in their guidelines stated that the drugs should be part of a treatment plan of obesity in children. Now, what else is there to come? Just to summarize, there's a lot of other medication coming. First of all, the drugs that we know now, semaglutide and liraglutide, they are being tested in younger children in the age group of 6 to 12 years old. And then some new molecules are also being tested. For example, amylin is being tested by several companies now. Also, the oral GLP-1 receptor analogs are being tested for obesity. In adults and soon also in adolescents with obesity. And then the next era will be a combination of several drugs. For example, tirzepatide is a molecule that is really promising because it is a combination of GLP-1 receptor agonist with GIP. With GIP is gastrointestinal peptide, which also centrally has an effect on satiety and decreases your appetite. Now, if you combine those two molecules, in the phase 3, in the first results of the phase 2 and phase 3 in adults, we see that there is about 20% decrease of BMI compared to the 16% we have now with semaglutide. The studies in adolescents are not yet running, and they will probably soon be starting as well. And then there will even be more combinations possible, combinations like GLP-1 with amylin, or even triple actions with GIP, glucagon, and GLP-1 receptor agonist. So we are not finished yet. We're just at the beginning of a new era of medication. This was not an effect that that I put in. But it's just the beginning of a long pathway that we will be seeing. Now, one last question, and a major question is, how long should we treat these patients? Because we know from the studies that as soon as we stop the treatment, almost all of them regain weight again. So what is the problem here? Probably it has something to do with the body fat mass set point. The set point is something we are born and influenced by genetic, epigenetic, and early life events, and that all gives us a certain set point, and we fluctuate a little bit. We put on 2 or 3 kilos, and then we lose it again, and then we put on, and we stay rather stable, normally, in normal circumstances, throughout life. But because of all of these obesogenic factors, this set point is little by little being changed, and we are now counteracting it with anti-obesity medications. But in fact, the solution should be that we find something how to change the fat mass set point again to a lower stable level. And that is something that a lot of studies need to be done and are little by little ongoing now. Before we find that answer, probably we will have to continue to give the anti-obesity medication, because otherwise everything will go back up again. So this brings me to the summary. I think the main point is we should try to avoid obesity, because once you have it, you have a chronic disease. It's not going away like this. It's just not eating less and moving more. You have a disease, there's a lot of pathophysiological changes behind it, and you need a chronic treatment as soon as you have obesity. If you do see a patient with obesity, treat it as early and as aggressive as possible. Because probably there are some studies saying that if you treat them earlier, you have a higher chance of remaining with your initial set point. And the longer you wait, the more problems you will have in returning back to the first set point. We have the new pharmaca. They offer us a lot of new things, reduction in weight and body fat, that's for sure. But also in the first results of the longer follow-up, we see reduction in comorbidities. And for sure, we are learning a lot about the pathophysiology by using these new drugs. And then we need, as I just said, more studies on the long-term effects of the medication and on the defended fat mass and weight set point. And by this, I would like to thank you for your attention.